Welcome everyone to our third webinar in our series, Head and Shoulders, Knees and Toes, Neurological Presentations and Serious Mimics, hosted by the Physician Learning Program, the Office of Lifelong Learning, and the Multidisciplinary ALS Clinic. My name is Melanie Hetherington, and I'm an education specialist with the Office of Lifelong Learning and the Physician Learning Program. Our mission here at the Physician Learning Program is to create actionable clinical information by engaging with physicians, teams, partners, and patients to co-create sustainable solutions to advance practice. We are dedicated to moving evidence into practice by fostering a culture and environment where everyone works together to tackle our most pressing problems. We acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. Just before we begin, I'd like to start with a bit of housekeeping information. So please use the chat feature if you have a question about technical difficulties or any of our programs and services. If you have a question for our speakers, please use the Q&A feature of the webinar. Please review what has already been asked and upvote those questions you would like to have answered. There may also be an opportunity at the end of our presentation for those of you who would like to voice your questions aloud. We can't guarantee that we'll be able to get to all of the questions today, but we will do our very best. We will be using Mentimeter for this presentation. If you would like to participate in the interactive discussions, you can scan the QR code on the screen or click the link that will be put into the chat. And this code will be presented throughout the presentation, so you'll have other opportunities as well. A recording of the webinar and a Pearls for Practice document with takeaways and resources will be sent via email to all of those that have registered after the 4 sessions have been completed. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credits. Participants can also claim certified credits by completing a personal development plan using the MyL3 plan. This is a free online tool that can be used to support the 3 activities or action plans required by the Physician Practice Improvement Program of the CPSA, and I'll be putting that QR code in the chat as well. So I would just like to welcome our 2 speakers for today. So for those of you who have joined us for the past 2 sessions, you'll remember Dr. Wendy Johnston, and we also have Dr. Diana Rouker here as well today. So Dr. Wendy Johnston is a neurologist who is certified to do EMG. She's a professor of medicine in the Division of Neurology at the University of Alberta and the former medical director of the K. Edmonton ALS Clinic. Her research focuses on neuromuscular conditions, including ALS. Dr. Diana Rouker has practiced as a geriatrician for 13 years. She currently is an associate clinical professor in the Division of Geriatrics at the University of Alberta. Her clinical research interests are dementia, frailty, and capacity assessments. So thank you both so much for being here today, and I'm going to turn the floor over to you.
We're at cross purposes here. We're unmuting and muting each other. I haven't done a conflict of interest disclosure slide for the last 2 sessions because they're very clinical and we didn't make any therapeutic recommendations. But a comment on our evaluations was that there was perceived bias or conflict of interest in that we push EMGs. So I am disclosing that Dr. Johnston does EMG a lot, and I'm afraid that sometimes I fall into the trap of to a hammer, everything's a nail. Today's presentation will be somewhat different in that we are collaborating in the Department of Medicine between geriatrics and neurology, as opposed to our last two presentations were those that I kind of work with day to day, whereas Dr. Rouker and I are both we're consulting specialists. Next slide. So our goals today is going to focus on very much on the key features of frailty, to share information about referral pathways and how to frame consultation to get the best bang for your buck in the realm of whether to refer to geriatrics or neurology for a senior with functional decline. I had originally, when I set up the framework for this series, talked about failure to thrive, but one of the outcomes of my meetings with Dr. Rouker in planning for today's visit is today's encounter is that failure to thrive is out. It's not currently used in geriatrics, so I have to ban it from my vocabulary. And we now are talking about functional decline. Next slide. So we're talking about frailty and functional decline, but our case presentations are two seniors presenting with falls. So we were wondering what you think of when you see on your list that one of your patients is coming in because of concerns about frequent falls. If you wouldn't mind, we're going to give you a minute. Just type in whatever crosses your mind. What's the reason for falls? And what will you be thinking about when you come to have your encounter with your patient? And so we are actually giving you 2 minutes to respond to this one because there's probably lots of typing. So log into Mentimeter. Think about as you're sitting, bringing your patient in or sitting ready for your patient. What's going through your mind when a senior is presenting with recurrent, frequent, or coming in because of falls? Please participate. Safety, good move. Yeah. Deconditioning, frailty, cognitive decline, excellent. Drugs, when in doubt, look at the drugs. Always a good move, particularly any new drugs that have been prescribed. Polypharmacy, yet again, a concern for our senior population. We have a few more seconds if anyone else wants to throw in their thoughts. 30 seconds to go. 6 people have responded, but 37 people have logged on. I'm looking at you. What are you thinking? Is there anything else that comes to mind when a senior presents with falls? Down to the last 5 seconds. We'll take what we get. These are all very good. Polypharmacy, family issues, interesting. Okay, looking at this holistically. So these are all really good thoughts and thoughts that can be explored in your encounter. Visual loss, so other senses. So rather than just being a motor problem, it's been brought up that visual loss, that could be other reasons, other senses that be involved. More are coming in. Neurologic change. Thank you. As the neurologist in this presentation, I am happy to hear that someone thinks of neurologic change. And we're getting chat messages about nutrition and hydration. Definitely hydration, deconditioning. I was going to say failure to thrive. All right, let's go to the next slide. So we're going to start off by comparing the two seniors at the basis of our presentation. So Diana, do you want to start us off with case 1?
Thank you so much, Wendy. So case 1, we have an 82-year-old female. She lives at home with her daughter and she gets home care twice a day. They do dressing her in the morning and evening and also medicines. She comes in because she has frequent falls in the past week. Last fall was 1 day ago when she was walking towards the kitchen and she fell, a ground level fall on her left side, and she was helped up by the grandson.
So my case is a 73-year-old who's a woman presenting from home with her husband. She's had 4 falls over a year. She reports that she feels her left leg is weak. It feels heavier and it doesn't lift as well. She's helped up by her husband and there's been no injury. Next message.
So going back to my lady, when you ask more, there's 4 falls in the last week. And she had similar increase in falls 9 months ago when she actually was diagnosed with COVID. The falls are not mechanical in nature, so there's no like things she's tripping over. She, when you ask her, she's a little bit vague and she says, well, my legs just feel like they give out. She has no symptoms of vertigo, so spinning. And she doesn't really feel lightheadedness when she's standing.
So my patient has reported 4 falls, and each one was a little different. One, they're all falls from ground level, one on the stairs. Her footwear is typically sandals or slippers. She doesn't report any postural symptoms, no lightheadedness. She has no pain, no sensory symptoms. And she again reports that the falls seem to be initiated by tripping, and then she just can't hold herself up and she collapses to the ground. Next slide. Over to you.
So with my patient, when you try to press and say, well, what happens when you fall? She can't really recall the fall or the previous falls she had. So you get collateral information from the daughter, and she says, well, she has decreased mobility. She sits in a chair all day. She watches TV. She doesn't like to walk because she has a fear of falling. And she had 4 falls in the past week attributed to poor balance. Sometimes she's like falling backwards, and we have a name for that. We describe it as retropulsion, when they're sort of like almost tipping back and they can't control themselves. They're not using a walker. Furniture walking is a common thing where they're like, she's hanging onto the walls or furniture to get around when she's not using the walker. The family is concerned about short-term memory, but has excellent memory from events 30 years ago.
So my patient is a good historian. She continues to work in the family business, doing administrative and accounting work. The husband reports he has no concerns about her cognition. She actually works out with a personal trainer 3 times a week who comes to their home and works with both herself and her husband. She's independent for IDL and ADL. She does not use a walk aid. Next slide. Over to you, Dr. Rouker.
Okay, so somebody brought up cognitive decline. So I just wanted to quickly go about how the diagnosis of dementia happens. When you look at the DSM-5, which is really the gold standard, it has like A, B, C, and D, but it's changed. And really what you need is 1 cognitive impairment and 1 functional impairment. So what's functional, all the basic ones are cooking, cleaning, are basically bathing, transferring, toileting, eating, dressing, mobilizing. And then the IADLs are like cooking, cleaning, shopping. But really in my world, the big ones are driving, taking your medications, and managing finances. So it sometimes gets tricky because you have to ask, if someone has cognitive decline, they may not be a good historian. So I always get this from collateral information. And sometimes you have to dig a little, like say personal finances. It might be that the husband has always done the finances and they don't know how. But, you can kind of probe a little bit and just say, well, do they have a debit card? If she gave change to somebody at a store, would she do it correctly, et cetera, et cetera. Now, the cognition part, there's 6 domains that we have now. And memory is a big one. And so the common one is people will say, oh, she's repetitive. She doesn't remember recent conversations. Language is a big one. So just even reading and writing less can be under that. Executive function is planning. And then complex attention, sort of multitasking. Social cognition is really like a change in personality. They're less empathetic, more irritable, often depressed. And perceptual motor is this visual spatial where people get lost easily or can't put clothing on, and praxis, so mistaking things for can't do simple motor things. So really what you need, the diagnosis of dementia is really, it's clinical. And so it's a history asking, like, do you have this? Do you have this? I don't need to do a blood test often. So I just wanted to review with that. I want to say The fancy word in the DSM-5 is neurocognitive disorder, major and minor. I like to stick with dementia because I want people to know what they have. And I try to just be positive on the diagnosis. Like if it's mild, I'll say, well, it doesn't really change your life that much. You're still the same person. Sometimes if people are overly sensitive, I'll use the neurocognitive disorder. But I want family and patients to know this is what you have. Because if you say you have a neurocognitive disorder, then someone will say, I don't have dementia, right? Next slide. So when we go back to getting even more history, there's no reports of syncope, headaches, LOC, seizures, fever, cough, chest pain, shortness of breath, no urinary symptoms, nausea, vomit, diarrhea. She's eating well. So we're really just getting like a review of systems. She was admitted for pyelonephritis and completed a course of antibiotics. And then she returned to the ER 3 days later due to swollen left hand. And they were questioning cellulitis, and she was treated for with more antibiotics. They also did a CT, and they identified a subarachnoid hemorrhage, a small one, but it was non-surgical. And then she was discharged home the same day. Since the ER, she has been using a two-wheeled walker, which belonged to her deceased husband, and physiotherapy was coming to see her at the home. When you see her in clinic, we do orthostatic vitals, and lying down, she's 152/91, and then she drops a little bit, but not within significant to 138/87. Her heart rate changes are 65 to 72. The patient herself denies dizziness, and this is really important to always ask, even if you don't have significant blood pressure raises or drops or heart rate rises, it's still really important to say, did you actually feel dizzy with that? Her CV and pulmonary exams are unremarkable. And then this curated neurological exam, she's orientated to herself, but she doesn't really know what year it is. She says it's 2012. Her motor strength and the hip flexors are 4 out of 5. And I put hip flexors because when you see people and they get deconditioned, this is one of the first sort of easy physical exams where you see it, flexors. Recently on one of those Apple News, it said, if you do one exercise, do this one the rest of your life, and it was squats. And so this is the same thing, right? Like you get decreased glute strength, hip flexor is, or like the ability to stand up. The tone appears normal. I always do tone. And this is just as a personal side note, I never want to miss the diagnosis of Parkinson's disease dementia or Lewy body dementia, because those are highly treatable and respond really well to the acetylcholinesterase inhibitor. And then otherwise, there's nothing focal. And when I see her gait, she requires arms of the chair to stand up. So she has to push herself up, and she has a shuffling gait. Which basically she doesn't lift her feet up, and the stepping distance of her gait is as well reduced. Next slide. So what is the next step at this visit or the next step? And the options are you would book, or if you happen to have time, get a MOCA or cognitive screen testing in clinic. You would order blood tests to rule out contributing factors like her thyroid. A urinalysis is always a good one, B12, of course. Refer to get an EMG study, refer to the neurologist, refer to a physiatrist, or refer to a geriatrician.
Westerly, since we had input from a participant that on their phone Mentimeter was slow, could we give them a bit more time? Thanks. So with 20 seconds left, we have a few more participants indicating the next steps they take on their own, and then some of the referrals that are being considered. Geriatricians are leading compared to neurologists, Diana. So that's at your end. More votes for the doing the testing that can be done in your own office. I'm just going to give it a few more seconds because it seems like Mentimeter does lag a little bit. Just to say, particularly with respect to my disclosure, while I as an EMGer would never say it's wrong to refer to EMG, I think an EMG would not be contributory in this case, given the predominance of central symptoms, the cognitive, the shuffling gait, and so on. I think a neurologist, again, can be very useful for achieving a neurologic diagnosis, but as we'll go on and discuss further as consultant, a patient like this is probably best off in the hands of a geriatrician if you feel that you need further support from a consultant. And we can talk about, the pros and cons and the pluses and minuses of neurologists in particular in this context at a different point. Next slide.
And I just want to say, doing testing with a MOCA in your office and just doing the basic lab work, electrolytes, and doing even an orthostatic blood pressure, these are all really great things. And yeah, geriatrician referral can be appropriate. Next slide. So when do you refer to an older patient to a geriatrician? So really, I never want to say I'm not going to see somebody. I like seeing a range of people myself, like from the really complex to somebody today who had only MCI. I don't mind seeing it, but really the complex older patient.
And MCI, you mean mild cognitive impairment?
Mild cognitive impairment. I don't mind seeing them, but they don't need to come to us, right? But again, I don't mind, but really it's the complex older people with multiple comorbidities related to cognition and function. So if they have dementia and mood disorders, polypharmacy, I do a lot of help with fitness to drive, capacity. If you as a family doctor feel comfortable managing all of these, and that's totally good, but I'm there to help. And then we said impacts on daily living. So these are just things like assessing, if they need home care, try to see if there's caregiver burden. These are people I will happily see in my clinic. Next slide. And Wendy, did you want to do this? Oh yeah, this is actually still me. Oh no, Wendy, did you want to, or?
No, this is your slide.
I didn't know.
You have to say when not to refer to. You just said that you don't mind seeing anyone, but there's pathways that you really yourself felt were better.
So with mild cognitive impairment, so typically these are people who have all their ADLs and IADLs, and they're just a little bit impaired. They don't really have to be seen by me. What I tell people is, I had 100 people like you, maybe 15 of them will in the next year start having functional impairment. We don't really recommend Aricept or the acetylcholinesterase inhibitors to be prescribed in the mild cognitive impairment. And really, you have to be positive with the patients and just say, you need to keep on being involved and do as much as you can. If they have a single symptom like falls, it doesn't necessarily have to be a geriatric referral. If it's something that, you can identify, like they had a UTI or they have orthostatic hypotension, we're just going to stop the Lasix or something like that, And if they have a single issue patients who are like, sometimes I'll get stuff like diabetes and heart failure, and I can manage, just because I am an internist, I can certainly see them. But if it's really like very specialized, then then it's probably better off at a specialist who does that, because I don't have those resources in my clinic or the knowledge to be quite yeah. Right.
Well, and as we were chatting beforehand, geriatricians come in two main flavors. There are the geriatricians who are CCFP and do an additional year care of the elderly. And then there are geriatricians who are general internists who've done specific subspecialty training and have passed an examination for geriatrics in addition to their internal medicine training. So you'd pointed out that as an internist, you can certainly provide feedback and support for a wide range of issues. But yourself and your care of the elderly colleagues focus really on the functionally impaired older patient with multi-system or multi-domain impairments.
Yeah. And sometimes, next. So the labs were normal for this lady. The MoCA was 16/30, which kind of puts her in the moderate range automatically in my head, mild to moderate. So she was referred to geriatrics. They confirmed the dementia diagnosis and discussed treatment options. They discussed home care supports and other available services. So there was a bit of caregiver burnout. And so for that person, we discussed maybe putting them, referring them to a day program. Now that happens through home care. I always encourage it, even when people are like, oh no, they're not going to like it. Sometimes they're really surprised, right? And and it's great, it's a longer version of respite than what home care would offer. Like they typically max out at 3 to 4 hours. So it sort of gives that caregiver a day where they aren't stressed out and can do stuff. We reviewed her medications. And then in this case, particularly because she seemed to functionally decline because she was discharged so quickly from the hospital, which is very common, and we're going to get to it, frailty. We put in a referral to the Glenrose Rehab Program, or SROP, to see if they couldn't work more intensely with her and get her strength back up. Next slide.
So we're going to take a pause there. As you recall, my patient, we're going to come back to frailty. We're going to come back to questions on your hand for the geriatrics. But we're going to come to the case that I billed as more neurological. So my patient, who, as you recall, is 73 and comes in with a history of falls. Further history indicates he has no syncope, headaches, pretty much a negative review of symptoms, and particularly no bowel or urinary symptoms, no B symptoms. Her orantic is normal. She has had no weight loss. Her medical history is pretty benign. She has diagnosis of COPD, not currently on meds, hypertension and hypothyroidism. She has one pill a day of hydrochlorothiazide, ECASA, which on further questioning was prescribed for primary prevention of vascular events, vitamin D and multivitamins. Next slide. So on exam, her postural vitals were normal. Her general examination was normal, cardiovascular. Even her musculoskeletal examination was unremarkable, no significant evidence of osteoarthritis, but she did have some stiffness of the left hip. The neuro exam at that time was she had a normal mental status, her cranial nerves were normal, and her upper extremity showed normal strength and tone. The right leg appeared normal, but the left showed mild hip flexor weakness, mild weakness of the left dorsiflexion and plantar flexion, but more dorsiflexion. So lifting the foot up was weaker than putting it down. But this seemed to improve if she really focused and took time to do the effort. At its best, though, it was still MRC grade 4 out of 5. Next slide. So what is your next step at this visit or the next? So we're giving this a minute and a half. So do you bring her back for cognitive testing or proceed if you have time that day, a test to rule out contributing factors, refer to EMG, refer to a neurologist, refer to a physiatrist, or refer to geriatrician? So we're getting a little bit of a preference to by area. After all, I am presenting the case. That's a little bit of bias on the part of how we're presenting the case today. So a big, little bit more of a trend towards doing some further screening equal referrals to physiatry and EMG and neurology, which of course could be bundled into one referral if we have a neurologist doing the EMG or a physiatrist doing the EMG. So anonymous, so the MOCA was not being used due to the fee to AHS, so the slums was being used. That is true. That was an evolution. That has been sorted out, and we're back to being allowed to do the MOCA. So
I can just talk a little bit about that. So yeah,
sure.
so what happened was we used MMSCs, and as many of you know or may not know, they started charging $1 per times you use test, and you couldn't get it like say if you were doing in the hospital, because they can't get into people's charts, but it was really aimed at research studies. But we also don't like the MMSC as much because it doesn't test executive function. So the MOCA is such a good test. And then right around, it was 2020, the MOCA announced that they were no longer free and that everyone who administered the test was going to have this license, and it was a couple $100. And so AHS was like, well, screw that, we're going to use the slums. The slums is a terrible acronym and stands for St. Louis University Mental Status Exams. It's sort of supposed to be the American equivalent of the MOCA, but it's just, I find it's a little bit of everything within each task, and people tended to score a lot lower than I think the MOCA, like 3 or 4 points, because the last part called executive function was actually really depended a lot on how well you could hear. It was like you read a whole paragraph to a person. And I think during COVID, people, were wearing masks, and so many of our elderly people lip read. So long story short, right around 2 years ago, MOCA said, okay, we're going to allow it again. You just have to take this online course and it's for free. And so now I rejoice because I much prefer the MOCA. It's sort of, I just like it a little bit better. So, but any test is okay that you do.
I love the MOCA. Another comment from a listener, I recall one patient was wearing flippers or sandals at home, closed footwear is recommended. Excellent point. So that's something that could be immediate feedback, and was a good historical point when the false history was being taken. And next slide, that was my patient with the foot drop. Next slide, yeah. So the follow-up visit in MOCA was done. It was 25 out of 30. The clinician reviewed plain x-rays that were done that showed symmetrical degenerative changes in the spine, hips, and knees. Nothing focal, nothing to really point to a reason why the left leg seemed a bit weaker. A CT had been ordered and was completed and was reported as normal. And the patient had been referred for physiotherapy and a left ankle foot orthosis and reported improved function and fewer falls. Next slide. The following year, she had a fall again, fractured her left wrist, had a closed reduction in casting, and then an open reduction internal fixation. Following this, her primary care provider ordered an MRI of the lumbosacral and thoracic spine, and there was a compression fracture at L2, mild stenosis at L3-4, and mild lateral recessed stenosis at the left L5-S1. Then referrals were initiated to physiatry, geriatrics, and then neurology. So the records that I had obtained did not show the physiatry and geriatrics referral, but a physiatry referral was completed, and then the physiatrist referred on to neurology. When seen by the neurologist, and now we're coming up to 3 years after the original presentation, the patient was now using a walker, but mostly a wheelchair. She reports again that only the legs are weak, left more than right, but weaker, and had been getting progressively weak over the last 2 years. She's having many falls, but she has no other symptoms, no cognitive, no sensory, no bowel or bladder, and no pain in the muscles, no pain radiating into the legs. And so at this neurology visit, next slide, her mental status and cranial nerves were once again normal. She had mild weakness of neck extension and bilateral shoulder abduction. So her deltoids appeared a bit weak. She had weakness of both legs at this time, but more on the left, and increased tone was noted in the legs. Again, right more than left, confusingly, with increased reflexes in the legs, but not the arms. The MRI of the LS spine was reviewed, and the neurologist felt that this was insufficient to explain the symptoms, and an EMG was requested urgently. Next slide. The EMG was done within 6 weeks, and a neurologic exam by the second neurologist was similar, although this neurologist did not report weakness of the neck flexors or extensors. This neurologist found increased reflexes in the right arm as well as the legs and a right Babinski response. Their conduction studies showed what was viewed as incidental findings of right median and ulnar neuropathies, very mild, and a mild peripheral neuropathy. The neurologist made the clinical decision that these weren't sufficient to explain her symptoms. The EMG, which is the needle study, showed reduced activation in the right leg, which is what we say when there's either decreased effort or actually those who have upper motor neuron signs and can't fully activate the muscle. You see the firing pattern on EMG is different. There was no evidence of lack of nerve input, so no denervation. So this neurologist ordered an MRI of the brain and cervical spine as well as some lab work. Next slide. So the MRI of the brain and C-spine were remarkable. And it was important that these were done because the patient had findings, according to the second neurologist, of increased tone in the legs, the right leg, and increased reflexes in the right arm, kind of pointing to the neck or above. The additional lab tests were unrevealing. Genetic testing was undertaken, which revealed a variant of unknown significance in 2 genes for autosomal recessive hereditary spastic paraparesis. So the neurologist made a provisional diagnosis of hereditary spastic paraparesis. Further testing could have been undertaken to evaluate this because it was a variant of unknown significance, but the patient declined. Prognosis was conveyed that it's a very slow progression of disability over years, and the neurologist said to see him in 1 year. Next slide. So when do you refer an older patient to a neurologist? Well, progressive weakness, obviously. Progressive sensory loss is another red flag, or certainly the two go together. So if you think a patient has a progressive neuropathy, that is a reasonable referral. Other neurologic changes that can include sensory changes, they can be multifocal, thinking more of multifocal vasculitis affecting nerves, rare conditions. When you can't nail the onset, so in our patient, she had insidious onset. She didn't come in and say, you know, I'm getting weaker. She came in and said, you know, I'm falling and I'm tripping over my foot. I think asymmetric findings is a very big red flag for referring to a neurologist in a senior rather than it being a general decline as in our first patient. And in particular, in an older patient, when a functional decline is not going along with a change in cognition. So our patient, the second patient, was still doing the family accounting at the time she was using a wheelchair. So this progression to further functional decline was very sensibly prompted neurologic evaluation. Next slide. Over to you, Dr. Rouker.
Yeah, so this is kind of just this concept of frailty, and I think we've often seen it. The red is like kind of your typical sort of normal youngerish person. They're at their sort of whatever baseline, and then something happens and they become dependent. They're sick in the hospital, and then they kind of minor. The green is the normal, and then they get better, and then they are back to their baseline again. And, there's lots of things you could throw in there. Like if you have injuries, for example, if you do lots of sports, if you do lots of prehab, you actually become stronger than your baseline, right? Now we go to the red line. The frail person is they drop to being dependent on people. They're hospitalized. It takes a lot longer to bounce back. And when they bounce back, they just are never quite as functionally independent as they were before. So that is kind of the definition of frailty. It's a decrease in the physiological reserve with a poor capacity to maintain homeostasis. Next slide. I don't want to get, there's different models of frailty. And I think just for you to be aware, there's kind of 2 big ones. I'm going to call them the American and the the Canadian one. So in the American and a lot of, even in Canada, the cardiologists are all over it. It's called the sarcopenic model. And it makes sense, but they really rely on like just testing gait speed or grip strength. And they've correlated it to a lot of things. And then just sort of the frailty, sort of a more holistic, which takes a lot of things into consideration. We use the clinical frail scale by a geriatrician back in Halifax, Kenneth Rockwood. And he has a much more complex way of doing it, but this is the ocular version, which I think is really helpful. This is what I would use. And you can just describe a person, you know, they're like frail scale 1 all the way through 9, right? And you can see kind of in the small writing, the kind of things that happen to them. Usually what I see is clinical frail scale 4 to 5. So with this, I just want to have one caveat, like you have to sort of, again, you know, if someone has, say, Parkinson's disease and they don't move very well or fast, then, or they have, we get this a lot, they have bad aortic stenosis and they're going for a TAVI, you know, they could be that their physical function is related to their underlying medical condition. So that sort of, you have to take that into consideration and think about it, but when you describe these. And one thing that Wendy and I came up with when we were kind of making this talk is when I see frail people, usually I see like they lose their abilities to manage those higher function, the IADLs, like finances and driving, taking their meds, being able to cook a meal before they lose their ADLs, their activities of daily living. The walker one, a lot of people are on sooner. That's sort of more independent because it's, again, so many things why you're weak. But in general, that's what happens. And in neurology, what Wendy will see is that it's just the ADLs, like the basic looking at being able to do the physical things go before the IADLs. Next. I just want to do a quick thing of how to refer to a geriatrician. So it's all centralized. So a lot of this isn't up to me, but it has to be a referral letter. But I know that's like, sometimes I want to refer to someone and I'm like, oh, can I just send you my progress note, which describes, and that's totally acceptable. So if in your progress note, you just even underline it or highlight and say, I'm going to send her to the geriatrician to sort out this, and print off that progress note, that's fine. And then the Alberta, this specialized geriatric outpatient referral, you can Google it or you can go through the Alberta referral directory and Google it, or you can just go to Google. I tried it myself with specialized geriatrics outpatient referral, and then you can see the form right there. They do want you just to tick all the little things. So just make sure you tick off all the different things, you know, like along each big box or whatever, but that's all it takes. Yeah. Next slide.
So how to refer to a neurologist or for an EMG. So I will separate these out even though the slide doesn't. So you can use the Alberta Referral Directory, and we are working to improve the Alberta Referral Directory to be a better resource for you for EMG. That's where the neurologist, if you see progressive weakness or progressive difficulty, which could be sensory as well in gait without the cognition changes. So referring to neurologists and EMGs is still not centralized, and there's pros and cons for centralizing referrals. Many people value the one-to-one referral because of a built-up relationship over the years, and that allows for more casual interactions. Say you want to expedite a referral, it's sort of overwhelming when you think, I've sent the referral in, nothing's happening. I just keep getting, you know, every 3 months I'm being told, yeah, they're still on the waiting list. What do I do? So central referral and triage has its pros in that you can see the soonest provider for an EMG, for example, or the soonest appointment for a neurologist. But the downside is that you can sometimes feel that you don't have a way to expedite things. So we're still in essentially a private practice model with hopes to start standardizing. So within the K. Edmonton Clinic, we're standardizing the triage so that there's central triage, and the patient, unless requested for a specific individual, goes to a particular goes to the next available appointment, which we think is better given our waiting list. Triage is done by a human, not by MOA, and we as a group have agreed on these how we're going to triage. We're hoping to move that out to all EMG labs over the next year, but of course that'll have to be in collaboration with our colleagues. EMGs are done by neurologists and physiatrists, and some practices have both. Some are more weighted towards physiatry. Ours at the K. Edmonton Clinic is all neurologists currently. And so depending on what you're looking for, you may prefer to send someone to a physiatrist, or you may prefer to have a neurologic opinion. And it's something to think about. Next slide.
Can I just add to that?
Sure.
In the referral form, we don't have to go back to it, but and I understand what Wendy was saying. You can, like in our referral form, there is a urgent or a semi-urgent, right in this service requested box. You can say urgent, semi-urgent, where it says other. You can also request, if you do have a relationship with a certain geriatrician, or they were, like, say, seen in the hospital. I try to book follow-ups for people that I think need to be seen again. But if you think someone, if they were seen before, if you put the condition, like say in our clinic, we have one geriatrician who likes to see osteoporosis. So the triage knows that, like I see with the ID clinic, I see HIV patients, so they will automatically come to me. But you can say, oh, here it says urgent appointment requested, or semi-urgent. But you do have to say, is it for capacity? It shouldn't be, like sometimes I've gotten urgent referrals for mild cognitive impairment, and that's a little bit not appropriate. But other than that, I think they try really hard just to have it be a fair system, and have it be efficient. Yeah, that's all I want.
And I think whenever you're filling in a referral form or referring letter, saying why you're concerned. So if you're saying urgent, the patient's only mild cognitive impairment, but they've changed over 6 weeks. So that's a different consideration. So the idea to just say a simple reason for the level of concern, and then if there's further progression, as in our other patient with her increased falls, that would be added, that there's an increasing urgency because her condition is changing. It's not static. Next slide. And then the next slide after that. So I'm going to skip over this because we've gone over this in the last 2 weeks. There's the shock and the needle for EMGs. So it's good for patients to know that if you refer them for EMG. Next slide. And so if you want to get the best out of your referral, the things that help to a geriatrician seeing a patient is if you could include any screening cognitive testing that you've done. If there's particular questions like a capacity assessment, clearly very appropriate for geriatrics. Elder abuse, caregiver burnout, safety issues, these are all highly important to know for a geriatrician to triage appropriately. Neurology, it helps to know if other consultants have been seen. You're referring to neurology, but you've already had an EMG done, or you've already had MRIs done. Anything that you can report from the history or physical exam to indicate the urgency of progression. Are there more widespread changes than just the presenting symptom of a drop foot? So those particular details are very informative to the clinician doing the triaging. Next slide. In the meantime, keeping an eye on a patient who's had falls, sending them for physiotherapy and bracing, as was done with our second patient. And then if you're concerned, sending a follow-up letter or even a phone call saying, this patient keeps getting you're on the waiting list. Can we expedite things? I'm worried. Their falls are increasing. And then the other thing that you think about is home care referral for occupational therapy, for walking aids, and environmental hazard check. So these are all things that can be done while waiting for the appointment. What if you do if the consult doesn't help you? Well, second opinion within a specialty, EMG from another specialty, revisiting the consultative request to say, send it back, say, no, I really meant this was progressive, or you can call someone. Next slide. So I do get calls from Rapid about progressive patients and advice over the phone. I actually really enjoy doing this troubleshooting. You can do virtual consults through ConnectMD, and you can do that through Connect Care as well. If you have access to Connect Care, sending a message through Connect Care can expedite things as well. Next slide. So the take-home messages from today, which is senior with functional decline, we came up with the IADLs being affected more, points you to more towards geriatrics. The other thing is that 65 and up is often called seniors in our society. You start getting the discount and so on. But really, seniors in terms of functional changes, if they don't have comorbidities, then decline in function tends to occur over 80. So patients with multiple comorbidities can have functional changes in their 60s and 70s. So they're almost like prematurely aged. But typically, a functional decline over 80 that's appears to be multifactorial, may have MSK, may have polypharmacy. These are really great to be sorted out for geriatrics. When to refer to neurology? Well, when they're actually having a functional decline that you can put your finger on, like they're really having a clumsy hand, they're tripping and falling, but otherwise seem fine. Because neurologists really focus on diagnosis, localization, what's going on, let me explain this. And they're really not as useful as geriatricians, honestly, when you really want to look at functional changes, getting community involvement, caregiver burnout. So geriatricians are more holistic than neurologists. Neurologists really want to get to the bottom of what's going on, but they aren't necessarily as helpful at community resources and the holistic family approach. Next slide.
No more
Is that
slides.
the last slide? Oh, okay, we're all done. Over to you, Mel.
Question about driving safety that I can answer maybe. So the question is, are there frustrations among geriatricians being sent an inpatient referral regarding ability to drive, especially a patient meeting you the first time, then having their license taken away? Okay, so I practice a little bit different than my colleagues, and I've been very vocal and strong about this. No, I don't mind sending that, but it's something the family doctor can also do. But I also understand that sometimes you just want to send them to me so that it's reinforced by someone. So generally, I follow what the Ministry of Transportation has, which is, it states that if you have more than 2 IADLs or more than 1 ADL impairment, you should at least consider an on-road driving test. So what I do, I refer them to the Ministry of Transportation. If they're really obviously, if I think there's if they've been drinking and driving 3 times, or if they've gotten into multiple accidents, I will just say, I think their license should be taken away. But I kind of do it I'm more, because it's such, as you know, it's such a big thing in someone's life to lose their license. So I will talk to family members and see it's safe. I'm not hardcore license is going away. I do not like sending them to Drive Able. I'm a bit of it's a lot of money. It's like $600. And then what really gets me is they send them back to me to tell them the bad news. It just blows my mind. And, so I don't like to send them to Drive Able. It's on computers, and I just feel like I would probably fail it if I had to do it. No, I'm just joking. But do you know what I mean? I try to, especially if they're mild cognitive impairment and they're managing. And I've had several patients where we've done this really safely, and then where the family member would call me and say, I don't think it's time. I don't think they're safe anymore. So then I fire off the letter to the Ministry of Transportation saying, please stop the driver's license. So I don't do it myself because it's not up to me completely. Does that make sense? I think that, I don't want to be, sometimes I do say you shouldn't be driving, but really someone else has to take the license away. I still can't do it. Does that answer your questions?
The other thing I hear is that there's a bit of variation in practice between yourself and other geriatricians. And I know there is some variation in practice amongst neurologists about who lowers the boom, shall we say. And I think sometimes having a consultant lower the boom is, I imagine, helpful to primary care physicians who are maintaining a relationship with the family, maintaining a relationship with the individual. So I can see that there's a kind of good cop, bad cop going on
there. And the question was, the wait list is 4 to 6 weeks, which is like so short in the world of medicine these days. But no, sometimes you're driving anyways, and if it's like a soft concern, then I'm not concerned. Or sometimes if I am concerned, if I'm really concerned, I probably will tell them you can't drive until you have your driving test on the road. So there's lots of ways. Every patient is like a snowflake. They're all different. And I always just, I have it on my list, every time I follow them up. Should we be talking about driving again? But everyone is different, if that makes sense. I try to be kind to the people. Yeah, that's all I have to say.
It's a tough one. Mel's going to come back on in a couple of minutes to do some final housekeeping. Please submit your feedback. I really look at it. Everybody's feedback. It's very meaningful. So when you put their feedback in, whether it's feedback on what would improve our presentations, feedback on whether this series would be one to repeat in a year, recommendations or wish list for further topics. We take this all very seriously. So please provide the feedback if you can squeeze it into your day.
Thank you for that, Wendy. You've basically spoken to my slide, so I won't continue with that one. As Wendy said, please do submit your feedback. As a thank you, you will have an opportunity to enter a draw for a $10 Starbucks gift card as well. So that's just a small token of our thanks. I also wanted to just let people know about our summit that the Physician Learning Program is putting on. It's called Advancing Practice Through the Power of Partnership. It'll be on June 11th here in Edmonton at the Chateau Lacombe, and our keynote speaker is Dr. Victor Montori from the Mayo Clinic. Registration closes on June 3rd, so we are really excited to have everybody there. If you'd like to participate, then make sure to get that registration in. And that was all that I had to present. Next week, we're doing speech change, is it always stroke, with Dr. Wendy Johnston and Dr. Carolyn Jeffrey. So if you haven't had a chance to register for that, then please do so. Thank you both, Dr. Rouker and Dr. Johnston, for an excellent presentation, and thank you everyone for attending as well.
Thank you so much for having me. Bye.
Bye-bye.